So today we're going to talk about a comprehensive approach to transition of patients with sickle cell disease. And we're going to be looking at a 15-year retrospective analysis. So sickle cell disease is an inherited genetic condition. Unfortunately, I don't have my glasses, and I'm trying to make this a little bit bigger.
I'm going to borrow some ugly ones?
Yeah. Thank you.
That help?
Yes, thank you. All right, so
I have to have it back for my talk.
thank you so much. So sickle cell disease is a genetic disorder characterized by chronic hemolysis, vaso-occlusive phenomena with progressive organ damage. Early intervention, preventative and comprehensive care have resulted in decreased morbidity and prolonged survival. However, transition from pediatric to adult care still remains a major national challenge. So the statistics from the New York State Department of Health from 2000 to 2008 shows that 1,911 New York State newborns were diagnosed with sickle cell disease. 1 in every 1,146 live births were diagnosed with sickle cell disease, and the incidence was 1,230 live births from non-Hispanic Black mothers, and 1 in 2,320 births from Hispanic mothers, and 1 in 41,647 births from non-Hispanic white mothers. So there's been some progress made in sickle cell disease. We have the New York State Newborn Screening Program. There's penicillin prophylaxis. There's transcranial Dopplers for stroke prevention. And there's the use of hydroxyurea. There are guidelines for red cell transfusion and iron chelation. And there's also stem cell transplantation. Despite all these progresses, though, there's been studies out there that have shown that increased anxiety, depression, social withdrawal, aggression, poor relationships, and poor school performance. And a few cases report also indicated high levels of parental anxiety, overprotection, excessive feelings of responsibility, and guilt. So young adults face major problems because of lack of sickle cell programs. There are really a few adult hematologists caring for young adults with sickle cell disease. There's a lack and absence of transition programs to help these young adults. There's sudden transition to adult life without patient and family preparation. There's a reluctance of young adults to transition to adult care. And there's a lack of interaction between pediatric and adult clinics or providers. So some of the consequences of poor transition: the development of chronic pain syndrome and opioid dependency, causing repeated visits to the emergency department and admissions. Many young adults develop the habit of using the emergency department instead of using it as a primary source of their medical care. There's chronic depression and lack of motivation. There's an increased number in disability cases and increased morbidity and mortality. So at 2 sickle cell disease programs in Brooklyn, New York, Interfaith Medical Center and the New York Methodist Hospital, we did a 15-year retrospective review of sickle cell disease patients who transitioned from ages 18 through 21 years during the period of 2000 through 2015. Both programs received state funding in 2009, which allowed for a transition navigator who played a central role in preparing parents and young adults for transition. So some of the features of our sickle cell disease programs are: we have a combined pediatric and adult program. There's comprehensive care, not only hematologic care available, but pediatric straight through adulthood. Adults and pediatric patients are seen in the same area, but on different days. So our clinic structure composes of a program director, pediatric hematologist, an adult hematologist. We have a nurse, a social worker, and a transition navigator. There's a clinic coordinator and a secretary. So it's not a whole big staff, but that's what we have. So some of the features of this combined program, there's the presence of the same stable support staff interacting with both groups of patients and their families. Parents and young adults are familiar with the adult physicians. The pediatric families have the opportunity to meet the adult physicians in informal settings, for example, at the holiday parties at Christmas time and during the clinic visits. At both institutions, patients are covered 24 hours a day and seen daily during admissions. The social worker works to ensure that there is no interruption of medical insurance coverage. So at Interfaith Medical Center, what we do at Interfaith is for a transition clinic. The young adults we have a clinic once per month where both the pediatric and adult hematologists treat the patients ages 16 through 21 at the same time together. Young patients between the ages of 18 through 21 have the flexibility of seeing either the pediatric or the adult hematologist in the same setting. At New York Methodist, it's a little different. Starting in 2003, a young adult clinic was established for patients aged 16 to 25 years to focus on preparing them for transition to adult care. Before 2009, patient education was done primarily by the physician, a social worker, and a community outreach worker. Starting in 2009, a transition navigator started and developed a transition action plan for patients aged 0 through 11, 12 through 14 years, and 15 through 18 years. So in our retrospective analysis, we included all patients who transitioned from pediatric to adult care between the ages of 18 and 21 for the period 2000 to 2015. We looked at barriers to transition, rates of delinquency, education and academic accomplishment, disease severity, depression, morbidity, and mortality. So we looked at 114 patients, age range from 19 through 35 years. 53% were male, 47% female. 62% of them were hemoglobin SS, 26% were hemoglobin SC, 4% was sickle beta thalassemia, and 8% were sickle beta plus thalassemia. Of the group, 64% were referred from New York State newborn screening, and the median age was 20 years. So we also looked at the level of education. And for high school graduates, we had a high percentage of 91% graduation rate. 9% did not complete high school. And the college rate, 18% graduated and 29 started but did not complete. So, for this psychiatric disorders, 16% had some form of psychiatric disorder, 4% suffered stroke, 3.5% a vascular necrosis, 7% leg ulcer, 3.5% priapism, 17% hydroxyurea, and 16% were lost to follow-up, and we had 2 deaths. So some of the barriers that we observed were the reluctance of parents and patients to accept the transition process, lack of communication between pediatric and adult providers, lack of education regarding transition, lack of education about the disease and treatments like hydroxyurea, and fear of being admitted to the adult floor. There's a big fear. They don't want to be admitted to the adult floor because they're so used to being on the pediatric floor and feeling the comfort of being with mom and dad. So at each center, patients had the opportunity to transition in a familiar setting. Building trust between providers and patient and family was observed to be of vital importance. Patients who were managed since infancy via the newborn screening program seemed to better cope with the transition to adult care than those who came at a later age. This may have been because they were introduced to the adult providers at an early age. Yet there was still a lack of knowledge about sickle cell disease in these patients and parents. So the impact of newborn screening. The majority of the patients that we looked at were referred from the New York State Newborn Screening Program. However, a large percentage were referred to both clinics at a much later stage in their childhood. Many of the latter group of patients were not born in the United States. So our results showed an excellent rate, a high rate of 90%. Other studies have reported much lower rates. While the college graduation rate was just 18%, 29% of the patients started college but ended up dropping out. We believe the stress of college life can contribute to health crises in patients with sickle cell disease, and providers have to find ways of helping students to manage their disease during this period. So with the caveat that this was a very small sample of patients, the rate of stroke, leg ulcers, and other sickle cell disease complications were less than 10%. The rates of psychiatric diagnosis, including depression and anxiety, was 16%. We believe psychosocial issues are prominent in this patient population and must be addressed in the transition process. So hydroxyurea was prescribed in 17% of the patients, reflecting underutilization of the drug. 18 of the 114 patients were lost to follow-up, some due to relocation, as I stated before, they moved out of New York State. The mortality rate was very low at 2%. 2 patients died over the period reviewed from 2000 to 2015, one at age 21 and the other at age 27, and they died. Both deaths were complications of sickle cell disease. Providing continuity of medical care throughout the young adult stages are likely contributed to this finding of low mortality. So what did we learn? We learned that the benefit of continuity of care from birth to adulthood, decrease in morbidity and mortality with coordination of care. There's an increased rate of survival of young adults, and the importance of empowerment of patients and parents. We also learned that even though transition took place in a single setting, many difficulties with transition process remained. Soliciting feedback from patients and families about their experience of the transition process will help to identify where improvements can be made. The transition process takes time, so starting education at a very early age is vital, along with constant reinforcement. So bridging the gap. So we found that the role of the transition navigator when we got funding helped a lot. So a transition navigator can play an important role in disease education, not only in the young years, but even much earlier, by teaching the parents of newborns and young children about sickle cell disease. The transition navigator can encourage goal setting and provide career guidance during the school years. In institutions that have separate adult and pediatric clinics, the navigator can serve as a link between both clinics. In such setting, the transition navigator can follow up with patients for up to 2 years post-transition. So some ideas for the future. We definitely need more clinics for adults with sickle cell disease that can provide comprehensive care. There's a need for appropriate funding for comprehensive centers and medical homes. Incentives to attract more adult providers to care for adults with sickle cell disease. Early collaboration between pediatric and adult clinics to foster and build relationship. And last but not least, strengthening of partnerships with community-based organizations. I'd like to thank the staff from New York Methodist Interfaith Medical Center and Kathy Harris from New York State Department of Health for contributing to this study. Thank you.